We'll start today's last session on Metabolic Matters, the fifth session. And this session, we have two things on the agenda. One is we'll be showing you how you can get your certificate for the entire duration of the course. The second part is we'll be discussing something on GLP-1 RA in relation with cardiovascular disease or with the risk of heart disease. Because at the end of the day, what's important for all of us is to live longer and to live healthier. And that's why it's very important that we protect our heart, because the heart disease is the number one cause of death in most people, especially in people who are obese or who are having diabetes or who are having metabolic syndrome. So we'll be exploring that aspect of it. We'll be also seeing some benefits of GLP-1 RAs beyond its role for weight loss. There are other benefits also. So we'll be discussing that also in today's talk. So we're happy to have Chirag with us. And Chirag, any thoughts on the last part and how our journey has been so far?
It's been great. I'm getting good response from the audience as well. Some of them personally texted me about it.
Right.
And today I'm very excited for the session, especially because we are seeing the heart diseases going up in our country and how we can solve it now.
Yeah, absolutely. So thank you for that. And thank you all for joining once again for this final part. And let me then share with you the first part of the session today. That is to show you how we can get your certificate. So what you'll have to do is you'll have to go to this website here, technochronology.thinkific.com or technochronology.com. You can directly go there as well. I'll just put this link in the chat, right? And yeah, so this is the link. Okay, and you can just use this link and you'll receive all this in the email also from Zoom. So when you go back, just check your Zoom email as well. And here, what you'll have to do is you'll have to go to the course which we have signed up for. If you're not done it, you should need to sign up for that. Okay. So this is the one I have already signed up. So it'll show me resume. So you just have to click on that. Okay. Once you go there, you will see this part. That is the, what is known as a learning management system and LMS. So you can go there and these are all the previous presentations and the lectures. So you can have a look at all of them. Right now, for each of them individually, you will have to go and just click on complete and continue, right? So all of these topics individually, if you're not done so, if you're not completed it already, you have to go there and just click on complete and continue. Even if you don't watch the whole video again, if you already seen it, already attended it live, just need to click on complete and continue for all of these, right? Now, what I suggest is please don't do it today. Wait for a couple of days. We generally upload all the fresh videos and some reading material by Thursday. So what I'll suggest is this weekend, you can check this out and then complete the process, because by that time, the certificate will also be ready for you to use. You'll go to all this and then go to the last part. You go to each of these topics and click on complete and continue. In the end, you will reach this part, which is how to get your certificate. Again, you click on that, the last part. So you'll have to go through all of them and just click on complete and continue. And then a pop-up will show up and that will tell you that your certificate is now ready. So you'll be able to download the certificate. The certificate will have, each certificate is uniquely coded. So each will have a certificate number. So you will be able to, it's a unique certificate for everyone, each and every with your name. And you should be able to download it and then you can print it and share it on your social media channels as well. Just one important point, when you're signed up for this, make sure that you're given the correct name, because the name which you use for signing up will be the same name which will show up in your certificate. And there's no way we can do anything about it. So just make sure that you're correct, given your correct name, because we get a lot of requests later on from people saying that the name has not been correct. So when the name is what you enter in when you're signed up. So if you're not done, you can sign up again with your correct name. So it's completely free to do that. So you should be able to do that. So that's how you'll get your certificate today. And I'm sure, it's a certificate of participation, but I'm sure it will be helpful for you again. And I think more importantly, the learning part, you'll be able to go through it again. And maybe, if you missed out something which is important, you could consider getting a sort of a refresher on that. Yeah. So that's the first part of today's talk. And then let me go to the second part where we are going to discuss today's topic. Now, just to kind of point out, the last session has been, so we had all the 5 sessions and we're thankful to two of our sponsors. That is the PFC Club, which Chirag is one of the founders of the PFC Club. And Chirag, can you tell us more about the PFC Club? And for those who are not aware.
So we help people in losing weight, in muscle gain and overall general health. We help them via online classes, diet programs, workout programs. And this is all done via an app, our PFC Club app.
Right. And so we're thankful to PFC Club for making this entire series possible. And the second sponsor, which again has been generous in providing again an educational grant for this, is an academic grant for this, is Cipla. And again, Cipla currently has some GLP products, and they are more coming up with more in the future. And they are apparently going to have the largest portfolio for GLP-1 products by next year. So that's their broad ambition. Cipla is also one of the largest companies for diabetes products as well as for respiratory. So the last part has been exclusively sponsored by PFC Club and Cipla. And the presentation which you're going to see has been given by Cipla. So there'll be a lot of elements of that also. But having said that, we will have our own touch also to that. And yeah, so let me just share my screen here and go on with the presentation. Right. So this is the topic of today's discussion. That is beyond blood sugar control and beyond weight loss control, the role of GLP-1 RA in conditions which are very important for all of us in terms of longevity and also in terms of well-being. So that is what we'll be discussing. Primarily, of course, our focus will be on heart protection or cardio protection. So that's the primary goal of what we are going to discuss in today's discussion. So again, a standard disclosure. This has been sponsored by Cipla. Cipla is a manufacturer of one very important GLP-1 RA product, which is called dulaglutide, which is available as once weekly injection called Trulicity. And again, they have been pioneers in this field. And Trulicity is the front runner to the modern day Mounjaro. So Trulicity is a single agent, whereas the Mounjaro is a dual agent. So that's again for your clarification. And these are the disclaimers. So let's then dig into the topic, diabetes and cardiovascular disease. So Chirag, in your views, longevity is very important. Do also discuss, do you have candid talks with your clients in terms of longevity? I'm sure there'll be clients of yours who will be often talking about how long can they live, what could be the mortality things. These are difficult discussions, but at some point, again, as doctors and healthcare providers, we do get this discussion. So any interesting anecdote you can tell us about any connection you had in terms of the people asking about longevity?
So after that, Brian Johnson got famous on social media.
Yeah.
Many people started talking about longevity. By longevity, I feel people want to live longer, but without disease or without heart ailments or any sort of lifestyle disorder. That is important.
So I think, as somewhat rightly said, it's not the length of the life, it's not how long you live, but how well you live, which is very, very important, right? So again, it's very important for us that we live healthy. And there are two conditions currently in today's world which often lead to complications that we see or that lead to death. One is heart disease. Heart disease continue to be the number one killer worldwide, right? Heart disease is the number one cause of death. And the second most important cause of death are cancers. These are two very important causes of death that we see. The problem with heart disease is that sometimes there could be certain heart conditions or heart related conditions which could keep you in a state which is very disturbing. For example, you could develop a stroke. So you could develop what is known as a hemiplegia, or one side of your body does not work. That is called a stroke. Sometimes you're not able to speak properly. So how good a life is when you're living, but you're not able to enjoy the full moments of life. So that's another challenge that we have. Some people develop some sort of a heart attack where the heart functioning becomes less. So the normal the pumping of the heart becomes slower. And again, in that condition, you continue to have difficulties in a lot of day-to-day activities. Like, for example, even walking to your bathroom may be difficult for you, right? Climbing up the stairs could be difficult for you. So heart disease lead to a lot of deaths. But even if you don't die, heart disease is also a very important cause of complications and poor quality of life. So that's why it's very important that, as Chirag said, not only is it important to live longer, but it's also very important to live stronger, right? And I think that's a very important message that we see, right? So if we see in terms of sheer number, annual deaths purely attributable to heart disease are 17.5 million every year, right? So this many number of people die of heart disease. The numbers are actually could be much larger also if you see. And very interestingly, and this is the group which is important for us, people with diabetes, right? 80% of people with diabetes actually die because of heart disease, right? So the number one cause, 80%, overwhelming, right? You can see if you're diabetes, you're most likely to die of heart disease. So anybody who has diabetes has 2 to 4 more times of developing a heart disease than somebody who does not. And it is particularly worse if your diabetes is not well controlled. Now, the same numbers, this is true for diabetes, but the same numbers are also true for somebody who has obesity. So somebody with obesity also tends to have a much higher risk of developing heart disease and much higher risk of developing complications because of the same. So that's why it's very important that there is a connection here, which we need to acknowledge and we need to understand. Again, the problem is that, of course, in a country like India, most of the healthcare actually comes from our own pocket, right? So we spend our own money. In certain countries, for example, in UK or in countries where you have socialized medicine, they tend to have spending which happens from the government. So government spends a lot of money on people's health. But in a country like India, most of the time, most of the money is spent by us. Now, you could be smart and you could buy an insurance policy and you could kind of subsidize some of the cost of any disease. But at the same time, not everybody has insurance or money to buy insurance. So that's also a common challenge. So the problem with having diabetes and problem with having uncontrolled diabetes from a financial perspective also is very, very potent, right? Cost for a patient who have diabetes is 3 times the person who do not have diabetes. But if you see diabetes, with heart disease, somebody who has diabetes with heart disease has 7 times the cost of somebody of any kind of economic burden in terms of healthcare from somebody who does not have diabetes or heart disease. So if you have diabetes and heart disease, you're 7 times more likely to have some sort of economic burden on you in terms of your health. And this number itself is quite staggering. That means that you have to work much, much harder, for the money you will have to spend. And it's much easier then to take care of your diabetes and take care of your heart problems or prevent heart problems before you develop. Now, then comes the $1 million question is that why do people with diabetes or why do people with metabolic problems like obesity tend to have more of heart complications? Okay, so this is where let me first tell you an interesting thing, right? Now, in your body, you have blood vessels, right? And these blood vessels, the ones which carry the blood in your body, right? There are two types, actually many types, but then there are two types which you have to understand. You have microvascular, so small blood vessels, and large blood vessels. Right? So of course, there are many ways of cutting the cake, right? But this is one way which is the one which is useful in our context right now. So you have small blood vessels and you have large blood vessels. Now, traditionally, diabetes management has been focusing on this microvascular complication. That is, how can you, if you have diabetes, how can you prevent you from developing, eye problem, which is called retinopathy, or if the blood doesn't go to your feet, so you develop, you can develop foot amputations and ulcers in the foot and so on. So these are all microvascular complications. But that is the era, maybe 10 or 15 years back, where the focus of any endocrinologist or any diabetologist or any physician was to control your diabetes so that you don't develop microvascular complications. But as world evolved, we understood that the complications are not just limited to microvascular complications. There is something beyond it. The larger blood vessels, the blood vessels which supply your heart, the blood vessels which supply your brain, right? Blood vessels which supply blood to your feet. These are all big blood vessels, and these big blood vessels are also having impact of diabetes on it, right? Now, earlier, you did not have any medications which could prevent macrovascular complications, but this all changed when two classes of drugs really emerged in this era, right? And these two classes of drugs, one was the GLP-1 RA, which is our hero today. Another is you would have heard about this SGLT2 inhibitors, right? Some of you would have heard about dapagliflozin or empagliflozin, Jardiance, and Forxiga. So these are the two classes of drugs which have changed the game in terms of diabetes management, right? They have something called, disease modifying anti-diabetic property, right? So these drugs actually change the disease from the core, change the disease from the root, and hence not only reduce the complications that you see because of diabetes, but also complications that you see, related to the heart. And that's why these drugs are in essentially game changers. in terms of diabetes management, right? We all hear from a lot of people that, root cause kya hai, what is the root cause of the problem, right? So this drugs actually correct the root cause. They actually do a root cause correction. And that's why they are very, very effective for heart disease and for related complications with that, right? So that's why these two classes of drugs are literally game changers. Now, one more thing which has happened as a consequence of these drugs coming into the market is that we all used to have, this cutoff, HbA1c, that is the 3 months average blood sugar. HbA1c more than 6.5% is said to have diabetes. And we generally try to target an HbA1c of less than 7% in patients who have diabetes. But these values make matter where we are just preventing microvascular complications. But in this modern era, we are not just preventing microvascular complications, but we are also preventing macrovascular complications. And in that era, this number actually has less meaning. You get the point? So the era which we are living in, we are just not preventing the problems with small blood vessels. We are actually preventing problems with large blood vessels, which actually matter more. That is your heart, the blood vessels that supply your heart and blood vessels that supply your brain. And in this particular context, the HbA1c cutoffs of 6.5 and 7% are actually more artificial and they don't make sense. So it is very important that somebody who has an HbA1c of 6% is treated as an equal risk as somebody who has an HbA1c of 6.5%, right? So the reason is that your complications for heart disease, your complications for retinopathy start at HbA1c of 6.5%, but your complications for heart disease actually start much earlier at a lower HbA1c. We don't really know at what HbA1c does it really start. And secondly, as we had discussed earlier, those people who have type 2 diabetes, they also have abnormally located fat in the body. And that also additionally contributes to the complications that we see. Insulin resistance is the problem which we have to understand, right? Insulin resistance can lead to heart disease and it can lead to diabetes. Okay. So when somebody with an HbA1c of 6% will also have insulin resistance. So the problem is that our concept of 6.5, ये नंबर से ऊपर गया तो इसको प्रॉब्लम है, ये नंबर के एक पॉइंट नीचे है तो इसको प्रॉब्लम नहीं है, ऐसा नहीं होता, right? It's a spectrum. That's why it is very important that in the era where you have newer medicines like your GLP-1 RA and SGLT2, we don't just look at the HbA1c number in terms of the overall risk. We also see the overall condition of the patient, the weight of the patient, and other things into consideration, right? So that's a very important mindset change that doctors need to do. A lot of doctors are still not aligned with this fundamental concept because they are still thinking that जब problem आएगा तब उसको हम solve करेंगे, right? When we reach that bridge, we'll cross it. That's not the way, right? You have to be proactive and you have to start treatment early. The reason is that the earlier you consider changing their lifestyle, whether it is diabetes, whether it is medications, whether it is exercise, whether it is diet, the earlier you start, the more likely you are to prevent the heart problem. Because time is very, very crucial in this kind of situation, right? So that is a fundamental concept in change in thinking that you all need to understand, and that doctors specifically also need to understand and accept that this is the fundamental change. So please do not deny a GLP-1 RA to your patient just because his HbA1c is 6%. Somebody who is obese, right, with a BMI of 32, right, who is already having huffing and puffing, right, that's a wrong way of looking at it, right? You have to see your patient or your client clinically and take a call on their behalf of when is the right time to treat. Now, let's come to the point where why does diabetes or why does obesity lead to heart disease and other complications, right? Now, it's a broad spectrum, but one thing which is fundamental to this is this condition called endothelial dysfunction. So your blood vessels actually are lined with a series of cells called endothelium. And what we now understand is that obesity and diabetes and chronic inflammation ultimately leads to some sort of an endothelial dysfunction. The blood vessels, which, the cells which line the blood vessels, they are the ones which are damaged or changed. And because of that, there is a fundamental change which happens in these blood vessels, leading to more diabetes related complications, right? So It's the endothelial dysfunction which is the root cause. So again, अगर कोई तुम्हें पूछता है कि root cause क्या है, patients come and ask them, sir, what is the root cause? Especially those who are in the managerial position, they have been always been taught that, root cause is endothelium problem, right? So you have the problem in the endothelium that leads to all these complications, and that is what we are essentially trying to prevent. Right. Now let's go to some numbers again. What studies have shown is that people who have diabetes develop heart disease about 4 to 5 years earlier than somebody who do not. Right. That means that, if you generally people develop, let's say, heart disease at 50, somebody with diabetes will develop a heart disease at 45. Right. So there is a tendency to develop complications early. That's why it is very important that we treat this also early. Right. Time is very crucial, right? Because agar patient ko already diabetes, pre-diabetes, the clock has already started ticking. And if you wait too long, you are just increasing the burden of the patient's complications which you are developing. Okay. Now, again, looking at the broader perspective, and now let's see a little bit from the obesity perspective also. Diabetes and obesity also have the close link, right? Which we, already have discussed in the earlier talk. In fact, 50% of Indians have obesity, right? With diabetes who have obesity. Now, एक fundamental change यहाँ पे भी है, right? This is what, again, doctors also need to understand. A lot of the times in our mindset, we have always been told that, Indians do not have obese, we have lean diabetes, more common, which is not true. Even in 2025, even Indian people who have diabetes, they are obese, right? 50%, 51% are obese. And if you actually go to a more stringent definition of obesity, as we discussed in lecture number 2, actually this number could be higher. So the point is that we have to then go back one step behind and say that obesity is the driver for diabetes and diabetes is the driver for heart disease, right? What are the strategies for reducing? So ultimately, what we understand right now so far is that obesity plus minus diabetes, both of these are linked with insulin resistance, and this insulin resistance is linked with heart disease, cardiovascular disease, right? And which are the cardiovascular disease? 3 important ones. One is stroke, right? That is less amount of blood reaching the brain, leading to hemiplegia. You could have heart attack and heart failure. So these are the 3 essential heart-related complications, right, which are resultant of these problems. And these are the 3 major causes of death worldwide, right? Number 1, 2, 3, right? Number 1, number 2, and number 3, right? Take any statistics. These 3 are the 3 major causes of death in any country, anywhere in the world, and in fact, any time period, right, in the last 100 years. So that is the fundamental thing which we understood. So how can you reduce the complications? Okay. So to reduce the complication as a whole, all the ingredients that lead to this complication have to be fundamentally tackled, right? So one is obesity. Okay. So your weight has to be reduced. Secondly, your blood sugar, right? So blood sugars have to be controlled. Third is your cholesterol has to be reduced. And fourth is your blood pressure, right? So you reduce your weight, you reduce your blood sugar, you control your cholesterol, and you reduce your blood pressure, right? All these things, if you do, you have reduced heart attack or reduced stroke, right? This has been fundamentally well studied. Now, how could you do that, right? One is, of course, individually, you could use different drugs for all these purposes, right? So you could use 4 different drugs for this or 4 different lifestyle measures, right? Diet plus exercise. Basically, the cholesterol lowering medicines, statins use karoge. But is there one thing or is there a series of things which can control all the 4 in one go, right? There is. It's GLP-1 RA. So GLP-1 RA individually has been shown to reduce weight, which we already discussed, improves blood sugar, improves cholesterol, and has some benefit on blood pressure also. So if you combine it with, again, exercise and diet, you have a very powerful tool to reduce heart disease. So a combination of GLP-1 RA with exercise with a good diet not only reduces your weight and makes you look better, but it reduces your heart disease. And that is the fundamental important thing, right? Even more important than you looking like Hrithik Roshan. It's very important that you live longer and healthier, which is far more important, right? So I think that is the ultimate goal which you should try and achieve, right? You had certain celebrities making it popular, but at the same time, it's also very important that उनके दिखावे नहीं जाओ, तुम अपना हेल्थ का सोचो, right? And think about your health and think about how you, not being Brian Johnson, probably could live longer, right? In your own way, with your own money. He's a billionaire. We are not, right? The point is that even with whatever money and resources that we have, we also could strive to live longer if we use our brains right, if we use our tactics in a strategic manner. So that's why a combination of these three things is very well known to reduce the risk of heart disease and reduce risk of complications. One is blood sugar आप कम करोगे तो क्या होगा? So what has been shown is that anything that reduces the HbA1c will reduce 21% risk of all cause mortality, right? So whether it is because of stroke or heart disease or anything, सब चीज के if you reduce the blood sugar, it will help, but it will only help to some extent, right? So there is one, right? So again, looking at the medicines, we already discussed this. These are the three classes. Of course, pioglitazone is something, it's a little controversial, so we keep it away. These are the two medicines which you use in diabetes which lead to heart disease. Now, let's come to some important evidence points, right? And if you remember, one of the key premise of this series, five-part series, was evidence-based discussion, which is very important, right? Nowadays, I see a lot of, Chirag, you've also seen a lot of videos on YouTube where, people, quote unquote, experts in their own way, come and give talks, maybe short clips of things, जो कुछ बोलते हैं, but they don't back it with evidence, right? And that creates a lot of harm.
Yes, yes, yes. Whenever we ask for evidence, they say ऐसा ही होता है, सालों से होता आ रहा है.
Right? So I think one essential thing when which I think this is where Chirag and I were on this common ground is that anything we say, we back it with evidence and data, because then there is a credibility to it. And that's why again, anything, the clinician of the future, the healthcare professional of the future is the one who talks evidence, who makes sense. Because आज के ज़माने में it is not very difficult for a smart patient or a smart client to just go and ask ChatGPT whether what you said is true or it is just complete BS, right? So, think about it. Agar you said something and your patient or your client goes and checks, or at that time, checks on his ChatGPT whether what you said is correct or not, and ChatGPT says that this is not true, तुम्हारी credibility क्या रही, right? Think about it, right? So it's very important that whatever you say, right, what you weight with evidence, right? Give more weight to it, and that's why whatever we said so far, let's back it with some amount of evidence, right? Okay, so this is where the evidence really comes. Why GLP-1 RA were game changers in this field from a medical perspective was not because they led to weight loss. Weight loss came, the game changer was this one trial, which was called the LEADER trial. And if you remember this, I told you in probably the last talk, the first drug which actually was a game changer in this group was liraglutide, which is still available in India in a generic form actually, so quite cheaper. So liraglutide was one injection which changed the game, because after a long time, you had this one class of drug which not only had other benefits, blood sugar reduction, weight reduction, and so on, but actually showed statistically significant reduction of heart disease, right? तो ऐसी चीज उन्होंने बनाई जिससे तुम्हारा हार्ट अटैक का चांसेस ऑफ हार्ट अटैक, चांसेस ऑफ स्ट्रोक actually reduced, right? And that is what ultimately led to a lot of these companies actually, trying to develop this group of drugs. Now, then came, what they realized is कि ठीक है, अच्छा है, heart disease तो कम होता है, लेकिन public को क्या चाहिए, भी कर रहा है. तो even though, they changed their strategies in terms of promoting these agents, the fundamental reason why these drugs were developed in first place were because they had remarkable benefits in terms of reducing the risk of heart problems. And that is what was game changer, right? And before, this slide is a little old in the sense that this was made, you can see it was published in 2021, before the newer drugs, that is the Wegovy, Ozempic, and Mounjaro actually came into the market, right? So what you see is oral semaglutide tak ka data hai, but uske baad ka data isme nahi diya. So the two trials, right, before the era of semaglutide really came into market were these two trials, which actually showed statistically significant reduction of heart disease. That is the leader trial and rewind trial. And both of these had a good substantial number. If you see patients, right, 9,000, 6,000, all these studies have good number. 10,000 patients per study karna is not a small feat, right? And clearly, these studies actually showed that there was benefits in terms of heart disease reduction. But interestingly, the leader, the kind of Mounjaro ka we'll say father of Mounjaro, that is dulaglutide, coming from the same company which makes Mounjaro, actually had some difference in terms of trial. They actually recruited more patients who did not have any heart problem to see whether they prevented. So if there is something called primary prevention, secondary prevention. So primary prevention is what? That तुम्हें कोई heart disease नहीं है, लेकिन I am trying to prevent a heart disease. Secondary prevention is somebody already having heart disease. You are trying to prevent second time having a heart attack, right? My mother-in-law had a heart attack or my father had a heart attack. I want him or her not to have another heart attack. What can I do? That is secondary prevention, right? If you talk about primary prevention, I don't have a heart attack. How can I prevent myself from having one? That is primary prevention. Most of the other trials actually looked at secondary prevention because it is much easier to prove. Dulaglutide, the rewind trial, actually looked at primary prevention. They had a substantial number of people who are in the primary prevention. Primary prevention is actually why it's more important, because these are people like you and me who never had a heart attack and who don't want one, right? So that's the point. So that's why there's a little different in terms of the trial. And this is where you see the benefit, right? So all these studies, actually, both these studies actually had a significant reduction of heart disease and stroke, right? And they take these 3 points, right? The 3-point maze. So there is, people who were on these agents compared to placebo had about close to 12 to 13% lower risk of developing heart disease and stroke. Now, remember, there is something called number needed to treat. And generally, these trials have number needed to treat of, when you take about 12% reduction, close to about 30, right? So that means if 30 people take liraglutide, one of them is going to have one, so you're going to have one less heart attack every year from that cohort, right? So, which is, if you see in terms of broad population, billions of people, look at the number of lives that can actually be saved. And these are all, in a sense, life-saving, right? So these are the trials. And then came the trial which came for semaglutide, which is called the SUSTAIN trial. The SUSTAIN trial is the similar heart protection trial, which was done with the currently available popular drugs, that is the Ozempic and Wegovy. And in this also, they actually found a significant reduction of heart disease and other complications, right? So ultimately, the point is that, and remember, these are not data which is for a short period of time. This is data which has been looked at patients who have been followed for a longish time. Now, generally, most of these trials follow up patients for about 5 to 10 years. And this is what has been seen. So, it's not just a short period, over a long period of time also, it prevented the patients from having heart disease and stroke, right? So this is the fundamental point, which is there. Also, another interesting thing was that it had other benefits also, which we already saw. So that, remember, when these trials were done, again, you can see this is a publication from 2019, so it's a little old. At that point of time, we were not very clear whether these drugs have benefit in terms of weight loss also. And that is where eventually people came to know, right? So this is a study from the rewind trial, which was done for dulaglutide, where they actually found that, this is placebo. So people who are not given the drug, and this is the people who were given the drug, right? And you can clearly see that there is a significant difference in terms of what weight they lost and how they maintain the HbA1c reduction and the weight maintenance over a period of time. So what these studies have shown, again, these were precursors to the modern day medications, where these studies have clearly shown that there is, sustained reduction of blood sugar as well as sustained benefit in terms of weight loss, right? Additionally, they looked at certain other benefits also. They found that a lot of these patients had benefits. And what they found was that, and which is again a precursor to some new things, this drug, dulaglutide, also had reduction in risk of kidney disease also, right? So what these studies have shown is that the kidney reduction is also reduced. Now, there is a trial on semaglutide called the FLOW trial, which has shown that these agents, so these are all extra benefits, right? That, weight loss to tumhara ho hi raha hai, डायबिटीज तो तुम्हारा कंट्रोल हो ही रहा है, cardiovascular reduction भी हो ही रहा है, but extra क्या benefit है? So these drugs also reduce kidney disease, right? So that's another extra benefit that you get from these drugs, right? So there were renal benefits also. Specifically, अगर आप देखें stroke की जब हमने बात की, so there are patients who develop, blood doesn't reach the brain and they develop something called a stroke where half of the part of the body does not work. Or sometimes you're not able to speak, or sometimes you're not able to, there was benefit in stroke also, right? So this is the first time. In fact, not many drugs have been shown to show this benefit. And dulaglutide was one which actually showed. Dulaglutide is available as Trulicity, still available in India as Trulicity, right? So all these benefits that you see. And then there is further benefits. So let's then enlist some of the other benefits that have been seen with GLP-1. So one is, of course, we all know this: weight loss, right? Heart disease reduction, and diabetes, right? So all these three benefits we are all well aware. But subsequent clinical studies have shown multiple benefits in other domains also. So one is kidney. So it gives kidney protection. It reduces the risk of, and that is what the slide I was showing, which is reducing the risk of dementia. Dementia is forgetfulness. You would have all seen people with Alzheimer's, or people with, your older people who have dementia, old age related. These drugs actually reduce the risk of dementia, right? Reduce forgetfulness, reduce all these complications also. So this also has been well known in this study. In fact, one doctor's mother-in-law, right, actually has dementia and she has obesity also. But, perfect agent for this patient is a GLP-1 because she will lose weight and it will improve, prevent the dementia from worsening. Some other benefits, and again, this is one more patient that I saw, knee joint osteoarthritis, right? So people who have arthritis of the knee, also there is benefit with GLP-1 RA. There is now benefit seen with fatty liver, right? That is known as MSLD, right? And there are individual trials for all of these, so you can just look up for all the clinical trials, right? There is benefit in fatty liver, and then there is benefit in PCOS also. One very interesting thing, and this is still the trials are not being published yet, but there are early small studies which have shown that, very interestingly, people who have addictions like alcohol addiction or drug addictions, semaglutide specifically has been shown to benefit those people also. So there is some anti-addictive behavior also with these drugs, and which are, again, these are all extra benefits that you see, right? So these are all, impact. This is the study which showed dulaglutide's impact on dementia and preventing memory loss and all these other complications. So with all this, right, this is the American Diabetes Association, ADA, sort of a gold standard organization for diabetes related advisory. And in this thing, right, again, if you see 10 years back, they used to talk about, metformin पहले देना है, फिर ये दवाई देनी है, फिर वो दवाई देनी है, फिर insulin देना है. What has changed is that now ADA is very clear that you should try to introduce either a GLP, and I'm not sure whether it's clearly seen in this slide, but what ADA said is that if your patient has high risk of cardiovascular disease or already has a cardiovascular disease, this patient should be given, beyond the usual medicines, should be given a GLP-1 RA, right? It has now very high place in diabetes management, right? It has now been on the top level in terms of diabetes management because of its benefit in terms of heart disease and the other benefits that we discussed, right? So this is the ultimate thing, right? Just to conclude, and to conclude the whole series, right? And we'll then have a more open discussions with Chirag and with all of you. I'm sure a lot of you have a lot of questions. But to conclude today's talk, and then please feel free to ask questions from some of the previous talks also. If you have any other question, you can raise your hand also. We'll allow you to speak. What I'd just like to conclude with today's talk was, what we wanted to see is that we already know that the GLP-1 RAs help your patients in terms of the weight loss, but do they have benefits beyond it? Yes. So there is heart protection, which is undoubtedly and undeniable, which leads to longevity and better well-being. And I think that's the fundamental process which we wanted to discuss today. So with this, I end today's talk, right? And we'll be opening this room for discussion. Yes, Chirag, any early thoughts?
I think we can take questions first.
Yeah, let's take the questions. Okay. So Ravi has asked a very interesting question, and I think we had discussed some bits of it, but not completely. Should you rule out gallbladder stones and retinopathy before this? Retinopathy, yes. So retinopathy is the blood vessels swelling up in your eyes if you have diabetes. So if your patient has severe diabetic retinopathy, which is known as proliferative diabetic retinopathy, you should not be giving GLP-1 RA to these people. But if the patient has mild diabetic retinopathy, you can give these agents. Secondly, should you rule out gallstones? Answer is no. Currently, there is no recommendation that you should check for gallstones, but also be very careful that gallstones can lead to pancreatitis. And sometimes what happens is that the patient develops pancreatitis because of gallstones and unnecessarily blames GLP-1 RA for pancreatitis. So again, as a good, prudent, good practice, एक अल्ट्रासाउंड करा के पेशेंट को बताओ कि देखो ये गॉल स्टोन्स हैं तुम्हें, right? Perhaps it would be a good idea to check up with your gastroenterologist to check whether you need a surgery for that. Because people that I know personally who are carrying gallstones who don't get surgery done, right? But when they have to be prescribed a GLP-1 RA, it is very important that this discussion should happen, right? At least tell them that you need to see a specialist for this and discuss with them whether you need a surgery or not, right? So that is something which is very important. Again, a good practice to consider doing. Right? Okay. Vikram has asked, GLP-1 RA are too good. What's the catch? Sarcopenia, retinopathy. Chirag, what's the catch? It's sometimes we always feel it's too good to be true, right?
Yeah.
So catch kya hai? Any catch any catch you feel which is there, right?
No, I don't see any catch.
You don't see any catch. Okay, good. Which is true, Vikram. I think we should stop probably looking at bad things that could happen and probably look at some good things that can happen. I'll tell you the catch. Okay, so the catch right now is the cost. Biggest catch is the cost, right? Not everybody can afford it. I think that's the biggest catch right now because these are expensive. But of course, since you're here, I'm sure you have patients and clients who can be prescribed this. Cost may not be issue for all of them. What I see is that in terms of long term, they actually have a lot of benefit in terms of cost saving. So maybe an initial investment at this point of time may not be that bad. The catch, however, is that it is very important that the right people prescribe this for the right patients and clients. This is very important. I think that's the biggest catch. Indiscriminate use of anything, as Spider-Man says, great power comes great responsibility. This is a great thing, but it also comes with great responsibility that we use it responsibly, use it for the right people, use it for the right patients. The catch really is to use it for the right people who will benefit rather than indiscriminately using it. I think that could be a problem, right? So yes, Chirag, anything you to add?
No, that's about it. The ethical
Yeah.
use is the most important thing.
Yes, right. Okay. Ravi has said, Ravi, we had discussed about optic neuropathy in the last lecture in quite detail. So you can probably go back and have a look at that again. Yes, Anonymous has said, are you planning more sessions in future? These sessions are, thank you so much, Anonymous attendee. You could have given your name, right? And yes, Chirag, we are planning something more of this as a collaboration or
We
yeah,
should. We should.
we should. Okay, so on technochronology, we are definitely having a lot of these courses. So if you're interested, we have courses on insulin resistance. These are more towards doctors. If you're not a doctor and if you're interested, you could still attend this. We have courses on AI, a lot of them related to healthcare. So a lot of these things are there. But of course, in this space, we would consider having more of these. If we could get the right collaborations with PFC again, and we could probably then look at, well, there are certain things we learn from these courses also from you, and we could use that as the learning in future. And there's one thing which Raghav has told me, and there's other feedback also, that there are a lot of, we should probably have a differentiating between whether we are having this course for doctors, where we could use medical terminologies more, and for people who are not doctors, we could have a separate course where we use less of medical terminologies. So I think maybe that could be a learning. Yeah. Vikrant, should you investigate patients for eye problem called it? Yes, I think Vikrant, we had discussed this in the last lecture again. So I would go. Answer is yes to all of these. Should you investigate for thyroid cancer? No. But we had discussed this point in detail. So generally it does not lead to thyroid cancer. In fact, there's just one study recently, just today published, right? It was published today. If you just follow either me or Chirag on Twitter, then I had retweeted somebody's tweet on this. There's actually a recent study which has showed that the thyroid cancer thing is actually probably not true, right? So there's a new paper on this. You follow one of us and you might be able to get that particular article. I would say, probably go and look at the last lecture, which was there last week. It is there on Endocrinology India YouTube channel and Technocrinology. You can have a look at this lecture and you will get a good idea. From a nutrition perspective, what things you should be careful while dealing with on GLP-1 RA? Chirag, we had discussed this. Anything you want to add? Also discussed, I think it was in lecture number 3 where we discussed this point. Yeah.
So just to repeat again, make sure your protein intake is adequate to retain your muscle mass and overall bone health, and make sure you are completing your micronutrient so that there are no any deficiency.
Right.
Plus, eat enough food so that the weight loss is not too fast. Otherwise, you will have energy issues and all.
Right. Yes. So very true. So I think, Kishore, I think we discussed this in great. In fact, there's an entire lecture on this particular topic. Lecture number 3. We'll reference that. Go back and have a look. Vikram has asked GLP-1 RA with BMI less than 24 with CV risk factor. Can you use? Yes, you can use, Vikram. There is no cutoff that you can only use it above a certain BMI. If your patient has diabetes and has a BMI, which is 24, as you are said, yes, your patient can be given GLP-1 RA, right? So there is no hindrance to that. Vikrant has asked about non-ischemic optic neuropathy. Vikrant, we had discussed this earlier. Let me just reiterate this point here. This was an early signal which actually came from a drug watch out group in Europe. So Europe has a lot of these drug regulators which actually keep looking at some of these things. So first and foremost, it was, always remember this fundamental point in medicine, or in fact any science related research, is that correlation is not always causation. The fact that if you have correlation of ischemic optic neuropathy does not mean that GLP-1 led to ischemic optic neuropathy. It means that the patients who were prescribed GLP-1 RA probably had higher risk of developing this complication. So that's first thing. Second thing is, so this has not been seen in prospective clinical trials, which there are more than, I think, 30 or 40,000 patients with semaglutide alone, right? This has been shown as a broad population-based follow-up where the causation has not been established. It's just a correlation. Secondly, a subsequent study was done in JAMA Ophthalmology, published in 2025, which we had shown as a paper in the last presentation, where it is clearly shown that there is no increased risk because of GLP-1 RA, but people who have diabetes and who have obesity are themselves more likely to have it. The same thing has been seen with other drugs also. Again, in that case also doesn't mean that the other drugs led to this. It means that the people who have diabetes have higher risk of this complication, right? So that's the first thing. You have to keep this in mind. There are more trials coming, and of course, this was only true for semaglutide because there is no such cases reported with tirzepatide, which is Mounjaro, nor with some of the other drugs also. So I think that is the whole nuance point. Having said that, it is very important that this is one area which we look out for, and the company which makes semaglutide is now coming with a dedicated trial to look at this particular problem in more detail, right? So we will have an answer soon in a few years. But till then, what I'll say is that if your patient is going to benefit, even if worst case scenario, at some level, we find that it does lead to this complication, the numbers are 1 in 20,000, 1 in 30,000, right? 30,000 लोग में एक लोग complication होगा, which means that fine, I'm all sympathetic to that, but the point is that we don't deny 29,999 people a drug which is life changing for them because of that, right? So that's something which we have to always keep in mind, again, in terms of prudent practice, right? Anna has asked, many people ask me about Mounjaro or Ozempic, which tests are applicable to know compatibility for taking these drugs? Anna, what I suggest is it would be a good idea to refer to your nearest endocrinologist or nearest physician or diabetologist who deals with this, and they'll be able to kind of, get the appropriate test and see whether your patient is a right fit or right indication for the drug. Okay. Again, we had probably discussed a little bit that this last time also. Any way of naturally occurring incretin in diet and exercise? We'll take this. So what the anonymous attendee has asked, is there a way to naturally increase your incretin levels so that you get the same benefits that you get from GLP-1 RA?
Yeah, by eating protein-rich meals, high fiber food, good starchy food, and healthy fats, and doing resistance training and aerobic activities. That is the best way to increase it.
Right. Absolutely. So again, there are other natural ways, like in the terms of gut microbiota also. So a change in the gut microbes also has been sort of linked with changes with the release of GLP-1 RA in your body and so on. Again, I think this was probably done in lecture 1. We are in the last part of the lecture. We already discussed some of these earlier. So what I suggest is go and have a look at the previous lecture. Somebody had asked about what courses are there for doctors. It's technocracy.com. I already answered that. I think we'll just take 1 or 2 questions and then we can call it today. Yeah. Vasant Lal has asked, macrovascular complications start from HbA1c 6%, and so in young diabetes, what is the target for HbA1c? Vasant Lal ji, we don't know that yet, right? So again, it's not very clear what should be the target of HbA1c, because again, these are all still new, right? What we have is from an earlier era in terms of the complication risk. We don't have data from new era, but what I'll say is that you should probably look at all the risk reduction in terms of everything, right? In terms of your how you could reduce the weight of your patient, your HbA1c of the patient. All this, as long as you do it safely and effectively, that is what should be your aim in your patients with diabetes. So that's the answer. Once GLP-1 RAs initiated, DPP-4 inhibitors are withdrawn. No, there is, Ravi, there is no added advantage of continuing DPP-4 inhibitors in these patients. Shailendra has asked, at what age can we start? Good question, Shailendra ji. At what age can we start GLP-1 RA? Again, we had discussed it a little bit last time, but what I'll tell you is that currently it is only approved for use in adults in India. So in India, you will be only able to use it in adults. However, having said that, there are already ongoing trials for adolescents. So we should be available. It's called STEP Teens trial for semaglutide in adolescents. So it should be available in children in near future. Okay, Vinod G has asked, do we need to watch? No, we don't need to watch the videos again, but just you have to go and click on complete and continue. Right. So for every individual lectures that you have on technochronology.com, you have to just click on complete and continue. And please just wait for a few days because we'll upload the new videos also. Sometimes when you do it early and then we upload a video later, you don't get the certificate. That's a bug which is there in the system. So just wait till this weekend, maybe Saturday and Sunday, and then you can go and do this. Just click on complete and continue, and it will go to the next lecture. All the lectures you have to do complete and continue. That's the whole idea, right? So I think we completed all the questions. Any parting thoughts? I think we had a long series. Today we finished on time, but in all fairness. So
good participation and good question. I learned many things.
yes. Great. Right. So I think thank you all for being a part of this for 5 lectures and engaging with us. I think that's the best part. As Chirag said, asking great questions. I think this, I still, I'll apologize in advance that if you're not be able to answer all of your questions. But what I feel is that, the fact that you came here and asked your questions and engaged with us, that's a job well done for us. At least we'll take that. And thank you for being a part of our journey. And I think I hope what I said, is that end of the day, we all want the best for our patients, right? So if your heart is in the right place, I think you would do well, both in your life as a healthcare professional, as well as helping out your patients and getting all the good karma there. And like I said, it's always a very important thing that we give the right advice, which is evidence-based. Sometimes some of these hard things that we say, the patients don't remember the good things you say. Sometimes it's the bad ones, right? Or you have a off-the-cuff remark, which patients often take to heart, which could be problems. And again, a lot of social media chatter and about, things. Do not blindly listen and trust and check with your own evidence, mechanism. And that is what really helps. Yes.
In the fitness industry right now, in the wellness industry, everyone is asking for these drugs as a shortcut. But
Right.
as a healthcare professional, it is our responsibility that we should advise people to take these drugs only when they need it.
Right.
Be as ethical as possible.
Absolutely. Great point. Right. So with this, we end here the 5-part series, and we hope to see you soon in another series soon. So keep following us on some of the social media channels, especially X or LinkedIn, right? And we'll be posting regularly there for these matters, right? So with this, we end Metabolic Matters. Thank you, Chirag. Thank you to all of you, and good night, everyone.
Thank you, Doctor.
Good night.
Bye.